Welcome to this revision-focused deep dive. If you are gearing up for board exams like the FRCS in plastic surgery, you are in exactly the right place.
Absolutely.
Our mission today is really simple. No fluff, just high-yield facts. We're getting straight into a rapid-fire Q&A to test and solidify your knowledge on chest wall reconstruction and congenital deformities.
Yeah, we are not wasting any time today.
Before we get into the material, though, press follow right now so you catch all of our future revision deep dives. And if you learned something valuable today, leave us a rating and drop a comment to suggest the topics you want us to cover next.
Right, those comments really help us shape the curriculum for you guys.
Exactly. And crucially, to really bulletproof your exam prep, you need to upgrade to our premium subscription. That is where you gain access to our exclusive journal club and the clinical cases deep dives.
These are just absolute game changers for your Vivas. I mean, you need that clinical application.
For sure. So we're framing today's discussion as a chronological journey. We'll start at the very beginning with the microscopic events in the womb, follow those resulting anatomical anomalies into childhood, and finally break down the reconstructive surgical triumphs in adulthood.
Sounds like a solid plan.
So to understand the matured chest wall, you really have to visualize what's happening embryologically. Let's lock down the absolute crucial timelines. When we look at fetal development, the 6th and 9th weeks are the high-yield milestones examiners want to hear, right?
Yeah, getting those specific developmental weeks down is foundational for the FRCS. So during the 6th week of gestation, you have this massive burst of coordinated development.
Right.
The ribs, the costal cartilages, and the sternum all begin their formation basically simultaneously. The chest wall is essentially laying down its primary scaffolding.
And then we fast forward a bit.
Exactly. Fast forward to the 9th week, and that's when the true ribs, meaning ribs 1 through 7, extend ventrally to actually fuse with the developing sternum.
Okay, and for anatomical completeness, you always want to remember your false and floating ribs here.
Right. Ribs 8 through 10 are your false ribs. They attach to the cartilage above them. And then 11 and 12 are your floating ribs with literally no anterior attachment at all.
Now, the sternum itself has a very specific, testable developmental pathway. It arises from paired longitudinal mesodermal bars.
Yes.
Normally, those bars fuse in a highly organized cranial to caudal direction to form a solid cartilaginous sternal plate. So when a patient presents with a congenital cleft sternum, it's not just a random defect.
No, not at all. It's a very specific failure of that exact embryological sequence.
So what's the timing on that failure?
The precise timing of that failure occurs during the 10th week of gestation. If that cranial to caudal fusion of the mesodermal bars halts or fails to initiate entirely, you're left with a cleft sternum.
Which is terrifying from a clinical standpoint.
Oh, absolutely. Understanding that 10th week timeline demystifies the pathology entirely. It's just a mechanical failure of fusion, which leaves the heart and great vessels dangerously exposed just beneath the skin.
Okay, so moving from the embryonic timeline into the mature anatomy, the intercostal space is a region you just have to know perfectly for reconstructive purposes. Visualizing this space in 3 dimensions is critical.
Yeah, you're dealing with 3 distinct muscle layers there. The external intercostal, the internal intercostal, and the innermost intercostal muscle.
But the absolute highest yield anatomical fact here, the one that dictates every single surgical approach to the chest wall, is the precise location of the neurovascular bundle.
Oh, 100%. The neurovascular bundle doesn't just sit loosely in the intercostal space. It runs in a very specific plane between the internal intercostal and the innermost intercostal muscle layers.
Tucked right up under the rib.
Exactly. It's tucked right up along the inferior border of the rib above it. It runs right in that costal groove.
Which dictates your surgical approach completely.
Right. Because of this exact positioning, anytime you're placing a chest tube, making a thoracotomy incision, or harvesting a rib graft, you deliberately graze the superior border of the rib below.
You stay as far away from that costal groove as possible.
Exactly, to avoid catastrophic bleeding or nerve damage. It's day 1 stuff, but examiners will ask it to make sure you're a safe surgeon.
Now, while we're looking at blood supply, the dominant vascular feed to the anterior chest wall and the sternum comes from the paired internal mammary arteries.
Right. They run parallel to the sternum, just deep to the costal cartilages.
And this becomes incredibly relevant later when we discuss pedicle flaps and sternal turnover procedures. But speaking of the mechanical integrity of the chest wall, Let's consider the physiological impact of extensive trauma or a massive oncological resection.
Yeah, when the skeletal framework is disrupted, you are immediately watching out for flail chest.
Define that for the FRCS candidate.
So flail chest occurs when that rigid framework is broken in multiple places, resulting in a segment of the chest wall just losing its continuity with the rest of the thoracic cage.
The classic clinical presentation being paradoxical chest wall movement.
Exactly. When the patient inspires, the negative intrathoracic pressure sucks that loose segment inward instead of it expanding outward with the rest of the chest.
But for exam and reconstructive purposes, you need a quantifiable threshold, right?
Yes. The threshold for inefficient ventilation, where the mechanics of breathing are severely compromised, is a flail segment greater than 5 centimeters.
That 5-centimeter rule really dictates the entire operative plan on the reconstructive ladder.
It does. If you have a skeletal defect that's less than 5 centimeters, it typically doesn't disrupt the mechanics enough to require rigid titanium fixation or bone grafts.
The surrounding intact ribs usually provide enough stability.
Exactly, meaning that smaller defect might be perfectly amenable to soft tissue reconstruction alone, like a regional muscle flap. But once you cross that 5-centimeter threshold, soft tissue coverage is just no longer sufficient.
You have to restore rigid skeletal stability to ensure the patient can actually ventilate.
Right. That mechanical relationship is the core of chest wall reconstruction. You're always balancing soft tissue coverage with the underlying dynamic requirements of the lungs.
Which leads us perfectly into the mechanical issues caused by congenital overgrowths rather than traumatic deficits.
Right, pectus deformities.
Break down the demographics and definitions for us.
Broadly speaking, pectus deformities occur in about 1 in every 300 live births. The underlying mechanism is an erratic overgrowth of the costal cartilages, which basically forces the anterior chest wall to buckle into one of 2 patterns.
Let's visualize those 2 patterns. Pectus excavatum is the concave, sunken chest deformity and accounts for the vast majority of cases.
Yeah, the sternum is displaced posteriorly, and in severe cases, it can literally be in direct contact with the vertebral bodies, severely compressing the mediastinum.
And pectus carinatum is the exact opposite.
Right. It's the convex pigeon chest deformity where the sternum protrudes outward. Carinatum is much rarer, seen in about 1 in 2,500 live births.
For FRCS level questions, you need to probe deeper into pectus excavatum. It has a strong 3-to-1 male to female ratio.
It does. But it's not just an isolated anatomical quirk. You'll frequently see it linked with systemic connective tissue disorders.
Like scoliosis and Marfan syndrome.
Exactly. Recognizing that systemic link is a crucial piece of the diagnostic puzzle for these patients. Now, while most individuals with mild excavatum are totally asymptomatic, a specific subset will present with genuine cardiopulmonary compromise because that posteriorly displaced sternum is physically restricting the heart and lungs.
This brings up a counterintuitive yet highly testable point regarding the physiological outcomes of surgery.
Yeah, this is a classic trap in the vivas.
Right, because when we operate on those symptomatic patients with severe pectus excavatum, we're physically elevating the sternum and expanding the thoracic cavity. You would assume this universally improves all cardiopulmonary metrics.
But the reality is much more specific. Surgery reliably improves the patient's cardiac ejection fraction because you are directly removing the physical restriction on the right ventricle, allowing it to fill and pump normally.
However, and this is the vital distinction, it does not significantly improve their baseline lung function.
Exactly. The pulmonary mechanics, the actual alveolar architecture, and compliance are often permanently altered by growing in that restricted environment.
So while you're dramatically fixing the cardiac output and the patient's exercise tolerance, you aren't necessarily changing their baseline spirometry results.
Spot on.
Yeah.
Now, to determine who actually needs this major surgical intervention, we rely on a radiological measurement called the Haller index.
Okay, visualize this for the listener. Imagine looking at an axial CT scan slice of the chest.
Right, you're measuring the widest internal distance side to side the transverse diameter, and you're dividing that by the narrowest distance from the anterior spine to the posterior surface of the sternum, the anteroposterior diameter.
A normal average Haller index is about 2.5.
Because it's a ratio, as the sternum sinks closer to the spine, that anteroposterior denominator gets smaller, which drives the overall index number higher.
So what's the threshold for surgery?
If you have a significant pectus deformity that warrants surgical intervention, you are looking for a Haller score greater than 3.25. That specific number is your trigger for offering an operation.
Let's break down the surgical reconstruction techniques for pectus excavatum, starting with the classic open approach, the Ravitch procedure, first described back in 1949.
The genius of the modern modified Ravitch isn't just in how it reshapes the bone, it's in recognizing that cartilage is a regenerative tissue.
Right, there are 5 key steps to articulate for the examiners here.
Step 1, you carefully elevate the perichondrial flaps off the abnormal costal cartilages. Step 2, you resect those overgrown abnormal cartilages, but you absolutely must preserve the costochondral junction.
Step 3 involves the sternum itself.
Yeah. You perform anterior sternal osteotomies, essentially scoring the bone to allow you to bend and mobilize the sternum anteriorly into a normal position.
Step 4 is stabilizing that sternum in its new corrected posture using wires, pins, or a metal strut.
And finally, step 5 is providing robust, soft tissue coverage by advancing and suturing the pectoralis major muscles back together in the midline over the reconstruction.
But Ravitch's original 1949 technique had a major historical pitfall that modern pediatric surgeons had to correct.
Yes, the original operation didn't utilize those perichondrial flaps, and it completely failed to preserve the costochondral junction.
So by aggressively resecting the cartilage without its lining, surgeons were inadvertently destroying the neurovascular bundles and completely obliterating the rib growth centers.
And the clinical result of that historical error was just devastating. You ended up with a rigid, ischemic, and stunted chest wall that could not expand as the child grew.
Acquired asphyxiating chondrodystrophy.
Exactly. The modern modifications fixed this entirely. By carefully peeling back and preserving that perichondrial sleeve, you're essentially leaving a biological blueprint behind. The patient's body uses that intact sleeve to regenerate brand new, properly shaped cartilage over the following months.
For exceptionally severe or asymmetric cases, you should also be able to describe the sternal turnover operation.
This is a massive, highly invasive procedure where you completely mobilize the sternal plate, but you leave it attached to the internal mammary pedicle to maintain its vital blood supply.
You then physically extract the sternum, turn it over like a coin, shape it with osteotomies so the concave surface is now convex, replace it in the chest wall, and wire it tightly into place.
It's a huge operation. Because of the morbidity associated with those massive open procedures, the Nuss repair, which was introduced in 1988, completely revolutionized the field as a minimally invasive alternative.
Walk us through the Nuss.
You make small lateral incisions on either side of the chest wall. You then insert a customized convex metal bar subcutaneously until it reaches the sternum.
And this is all under strict videothoracoscopic guidance, right?
Which is non-negotiable for avoiding injury to the heart or internal mammary vessels. You carefully pass that bar retrosternally, right underneath the depressed sternum and out the other side.
The Nuss procedure is essentially an orthopedic trick applied to the chest cavity. You insert the bar with its convexity facing posteriorly so it perfectly matches the sunken deformity of the chest.
Right, and once it's safely across the mediastinum, you use surgical flippers to physically rotate the bar 180 degrees.
That flipping action forces the sternum anteriorly, elevating it immediately with immense mechanical leverage.
Over the next 2 to 3 years, the ribs and costal cartilages just remodel around this new shape before the bar is eventually removed.
But examiners will absolutely want you to articulate the massive caveat to the Nuss procedure.
Yeah, it is highly effective in children and adolescents whose chest walls are still pliable. However, it is generally contraindicated, or at least highly fraught, in mature adults.
Because once skeletal maturity is reached, the adult chest wall becomes extremely inflexible.
The sheer mechanical force required to flip that bar and hold a rigid adult sternum forward is immense. It places massive stress on the ribs acting as hinges, leading to a high rate of bar displacement, rib fractures, and severe chronic pain.
So what about the management of pectus carinatum? It requires a completely different approach.
It does. Because the sternum is protruding outward rather than compressing internal organs, you have a highly effective non-operative option for growing children.
The custom-fitted compressive brace.
Exactly. The protocol is strict, though. The patient has to wear it for 14 hours a day for 2 full years.
It relies entirely on the plasticity of the pediatric skeleton. The brace provides continuous antero-posterior compression that progressively remodels the cartilaginous overgrowth,
slowly flattening the chest wall over time. Now, if they're non-compliant, fail conservative management, or present with a deformity that's just exceptionally rigid, you then pivot to operative management,
which involves modified, reversed versions of either the Ravitch or Noose procedures to physically flatten the convexity.
Right.
Okay, moving on to a massive topic for plastic and reconstructive surgery, Poland syndrome. To understand the clinical presentation, it really helps to look at the history.
First described in 1841 by Alfred Poland while he was a young anatomy demonstrator at Guy's Hospital in London.
Imagine being in a 19th century dissection room, mapping out the human body, and coming across a cadaver missing an entire section of its chest musculature.
It must have been wild. Demographically, Poland syndrome affects about 1 in 30,000 people.
Predominantly sporadic, meaning it occurs randomly.
Though rare familial cases do exist, hinting at a potential underlying genetic susceptibility. It's twice as common on the right side of the body in males, and it's exceedingly rare to see it bilaterally.
The textbook male-to-female ratio is cited as 2 or 3 to 1. However, in modern clinical practice, you'll see far more female patients seeking surgical consultation.
That clinical discrepancy makes perfect sense because female patients are typically presenting for the management of the resulting breast asymmetry.
Which becomes profoundly apparent during puberty.
Exactly.
So the etiology of Poland syndrome traces directly back to those embryological timelines we discussed earlier. The leading theory is a highly specific vascular developmental anomaly.
An interruption, hypoplasia, or microthrombosis of the subclavian artery during the critical 6th week of embryonic development.
This transient ischemic event arrests the development of the specific musculoskeletal tissues supplied by those vessels.
And this vascular theory perfectly explains why Poland syndrome is so frequently associated with other congenital anomalies, like Mobius syndrome and Klippel-Feil syndrome.
Mobius, which involves facial paralysis, and Klippel-Feil, which involves the fusion of cervical vertebrae.
Right, they are thought to be caused by a similar ischemic event, just involving a more proximal segment of the subclavian artery or its larger branches. It basically represents a contiguous spectrum of embryonic vascular disruption.
When a patient is standing in front of you in the clinic, the physical examination is striking. The absolute pathognomonic sign, the one feature that defines the syndrome, is the congenital absence of the sternocostal head of the pectoralis major muscle.
While the clavicular origin remains completely intact.
You'll see a functioning, distinct muscle belly near the clavicle, and then a profound skeletonized hollowing beneath it across the rest of the anterior chest.
But the syndrome is a mosaic of deformities affecting both the chest wall and the ipsilateral upper limb.
On the chest, alongside the missing pectoralis, you'll see absence or severe hypoplasia of the breast tissue and the nibble areola complex, which is often displaced superiorly.
There's a noticeable lack of subcutaneous fat and axillary hair. You might find complete agenesis of the pectoralis minor, the latissimus dorsi, the serratus anterior, and the external oblique.
Skeletally, the rib cartilages can be so hypoplastic that you literally see paradoxical lung herniation through the skin when the patient coughs.
Looking down the arm, the classic upper limb findings are abnormally short limbs and brachysyndactyly,
which presents as short, webbed fingers on the affected side.
Right.
Transitioning into the surgical treatment of Poland syndrome, let's break this down by tissue type, starting with breast reconstruction strategies. Managing this profound asymmetry is incredibly challenging.
Especially considering these patients almost always present as teenagers when the deformity becomes really obvious.
Timing and staging are everything here.
In adolescence, the contralateral healthy breast is still actively growing. You absolutely cannot perform a definitive static reconstruction because the target volume is constantly moving.
So the gold standard approach is to use adjustable tissue expanders.
Placing an expander allows you to gradually inflate it in the clinic over months and years, continuously matching the volume of the healthy breast as it develops through those crucial teenage years.
Once the patient reaches skeletal and hormonal maturity and breast development is fully complete, we swap that temporary expander for a definitive solution.
You have a wide reconstructive ladder to choose from at that point. You can replace the expander with a definitive silicone implant.
However, because the sternocostal head of the pectoralis major is missing, you have exceptionally thin, poor quality soft tissue coverage over the chest wall.
To prevent implant visibility and extrusion, you often have to recruit regional tissue to cover that silicone implant.
This usually means harvesting a latissimus dorsi or LD muscle flap from the back.
Or utilizing a thick sheet of a cellular dermal matrix, an ADM, to act as an internal bra.
Alternatively, you can bypass implants entirely and opt for a wholly autologous tissue reconstruction.
This could involve a pediculed ipsilateral LD flap, a free contralateral LD flap, an omental flap, or moving abdominal tissue using TRAM or DAP flaps.
Increasingly, massive lipomodeling, or staged fat grafting, is being heavily utilized as a standalone procedure or to refine the contours of flap reconstructions.
That covers the breast mound volume, but recreating the broader chest wall defect requires a highly specific surgical maneuver. You have to reconstruct the absent anterior axillary fold and fill that massive bony infraclavicular hollow.
The absolute workhorse for the anterior chest wall in colon syndrome is the latissimus dorsi transposition flap.
But you must describe this carefully for the examiners because it's not just a standard LD flap used for coverage.
To recreate that nothing anterior axillary fold, you're completely mobilizing the latissimus dorsi. You transpose its origin anteriorly.
Crucially, you also have to completely detach its humeral insertion from its normal posterior position. You then swing that insertion anteriorly and suture it directly onto the bicipital groove of the humerus.
That specific orthopedic repositioning physically mimics the missing pectoralis major muscle, restoring the dynamic fold of the axilla and heavily masking the infraclavicular hollow.
In cases where the bony defect is profound, where you have hypoplastic or completely absent ribs leading to structural instability and lung herniation, you have to reconstruct the skeleton itself.
Surgeons typically harvest contralateral costal cartilage grafts from the healthy side of the chest. But the high-yield technical point here is the periosteum.
Just like in the Ravage procedure, you must meticulously dissect the cartilage out while leaving the donor rib's periosteum securely behind in the normal chest wall.
Leaving that intact periosteal sleeve is non-negotiable.
It is the only way to ensure the donor site regenerates its own cartilage, preventing you from simply creating a new chest wall defect on the healthy side to fix the Poland side.
Now, regarding male patients, they obviously don't require breast mound reconstruction, but they still present with a severe contour deformity that causes significant psychological distress.
For males, customized solid silicone chest implants are an excellent option to fill the muscular void. These are 3D modeled based on the patient's CT scans.
However, careful preoperative counseling is mandatory. Because there's no functional pectoralis muscle to cover the implant, the silicone borders can be quite visible beneath the thin skin.
It risks looking very unnatural, especially when the patient flexes their surrounding shoulder musculature, because the implant remains entirely static.
Because of this, an LD transposition flap is often still required in men, not for breast volume, but simply to provide a natural, dynamic, contracting contour over the implant.
You're constantly managing the downstream effects of that initial embryological stroke. The reconstructive goal is restoring both form and mechanical function, utilizing every flap and graft in the plastic surgery arsenal to compensate for a microscopic vascular event that occurred in the 6th week of gestation.
Before we wrap up, I want to leave you with a thought that builds on everything we've discussed today. We spend so much time talking about harvesting autologous tissue, taking contralateral ribs, mobilizing the latissimus dorsi, rotating abdominal flaps, all of which carry significant donor site morbidity. But consider the rapidly advancing field of tissue engineering. Imagine a near future where, instead of harvesting a healthy rib and carefully leaving the periosteal sleeve, we simply use 3D-printed, bioabsorbable nest bars seeded with the patient's own lab-grown chondrocytes.
We could regenerate the missing costal cartilage from scratch, completely bypassing donor site morbidity.
We're moving from merely rearranging the body's existing parts to literally printing the missing embryological blueprint. It fundamentally shifts the entire paradigm of chest wall reconstruction.
It's incredible to think about where the field is heading.
That wraps up our deep dive into chest wall reconstruction and congenital deformities. Remember, to really cement this knowledge and get full access to our exclusive clinical cases and Journal Club deep dives, you need to upgrade to the premium subscription.
It is the best investment you can make for your FRCS preparation.
Keep studying hard, trust your training, and we wish you the absolute best of luck in your exams. See you on the next deep dive.